Hello, my name is Mark Lewis. I am a medical oncologist at Intermountain Healthcare in Salt Lake City, Utah. And the other thing you should know about me is I am a NET patient myself. So I'll be speaking to you today about NET advocacy in the modern era, giving you my perspective from sort of both sides of the exam table. So let's start with the journey of the NET patient. I think one of the unique challenges that I see in my practice, and I take care of all different types of gastrointestinal cancer, is this sense of not being recognized for what you have. So we all know that the zebra is the mascot of the neuroendocrine tumor patient, but I wanted to explain where that zoological association comes from. So in our medical training, the adage that we're taught as students is when you hear hoofbeats, think horses, not zebras. And what that means is in medical school, we're taught about almost literally every illness. But our instructors, our professors, our attendings want to focus our attention on the things that are most common. Ergo, horses are more common than zebras. However, if you just think about horses, you're going to miss zebras. And as we'll discuss, in aggregate, we form, I think, a fairly impressive herd. The other thing that doesn't help, if I'm honest, is the name of neuroendocrine tumors. So, Shakespeare said, what's in a name? That which we call a rose by any other name would smell as sweet. I wonder if neuroendocrine tumors by any name other than carcinoid might be more comprehensible and better understood in the medical community. So let's start with carcinoid. This is a misnomer that has existed in our community now for over a century. And it begins with this gentleman. This is Dr. Siegfried Oberndorfer. He was a brilliant pathologist practicing in Germany, in Munich, in the early 20th century. And he made a seminal discovery, which he was examining patients. And this sounds morbid. He was doing post-mortem exams. And in roughly one in several hundred autopsies that he was performing, and he was doing very meticulous work, you would find these tiny, tiny tumors, typically in the small intestine. And he couldn't discern that the tumors had spread. And also under the microscope, like you can see there, he's peering down the lens, they didn't have the classic appearance of a cancer. And so he decided that the proper term here would be carcinoid, which is as close as we can get translating the German to English, the meaning cancer-like. The problem is, and Oberndorfer actually realized this before the end of his life. He was a Jewish scholar, and he had to leave Germany during the Third Reich and actually live the rest of his life in Istanbul. Before he died in the 1940s, he tried to fix this misnomer, but unsuccessfully, and it's a term that has stayed with us ever since. What he wanted to avoid was it being interpreted as uniformly benign, because even he realized shortly after the genesis of this term that that was not the case. That these tumors could spread and they could cause significant problems to patients, both in terms of quality of life and longevity. So I'm also going to invoke another titan in the history of neuroendocrine tumors. I don't know if this name is as well known to NET patients as perhaps it ought to be, but Dr. Charles Mortel was a titan in the field of GI oncology who practiced at the Mayo Clinic, largely, I believe, from the 1970s to the 1990s. And in 1987, he gave this brilliant lecture. It's actually one of my favorite scientific papers of all time, called An Odyssey in the Land of Small Tumors. And he specifically was drawing attention to the under-recognized plight of the neuroendocrine tumor patient. And he had a beautiful turn of phrase. This was not dry scientific jargon. This was full of verve. So he said, these patients have a natural history of disease like no other. They present in an almost serialistic manner a mix of tumor-related symptoms and signs with bizarre and sometimes grotesque endocrine syndromes. Certainly, they are only rarely encountered, but as specialists in oncology, it's our responsibility to understand the less common diseases. The privilege of caring for a patient with a gastrointestinal neuroendocrine tumor is one to be savored. So clearly, this man was advocating for us. And then what's interesting is when you try to take the experience of each individual patient and quantify that, look at that in aggregate. Indeed, there are a whole host of different symptoms that a neuroendocrine tumor syndrome can present with. As you know, like a variety of mimics. So the diarrhea of carcinoid syndrome can look like irritable bowel syndrome. The flushing can look like, especially in a woman, can look like perimenopausal hot flashes. The wheezing can be mistaken as asthma. But when you put that all together, what that means is if you're accruing these incorrect labels, there is a significant time delay to onset of symptoms and proper labeling. And that time delay can last years. In this aggregate study, it lasted 53.8 months, so about 4.5 years. And indeed, I think if you look among our community, I think you'll find some people had a mercifully brief journey to diagnosis, and some people had years, sometimes even decades, of suffering the symptoms and not knowing what was wrong with them. And this is, again, something that Dr. Mortel realized. So among doctors, I have to be honest with you, there is a sense that patients should not be going to the internet to research their own illness. However, I have to tell you, I think that is an entirely natural, and I would argue, depending on where you go, appropriate thing to do. So let's look at cancer patients in general. Most cancer patients, the vast majority, use the internet to search for information about cancer following their diagnosis. 94% of them search on Google. And these are the results they tend to get back. So the most accurate findings a Google search will give you is about the cause of your disease, although this is not a net-specific finding because, as we know, the cause of many nets is elusive. And then about symptoms, about 2/3 of the search results will be accurate. Where the least accurate information arises is prevention, treatment, and prognosis. So it's very easy to get a skewed view of your likely outcome by using Google. There are trade-offs between readability and reliability. As a general rule, the simpler the language is, the less reliable the scientific conclusions might be. And this is fascinating for our community. Patients with rarer cancers are particularly vulnerable to the surfacing of misinformation. Remember that Google is a search engine, and search engine optimization can be gamed such that results that rise to the top are trying to sell you something, and not always something that's going to help you. Searching about specific medications will lead to pharmaceutical websites about 1/5 of the time. And I'm not saying that that's an unreliable source, but those websites typically exist not just for educational purposes, but for marketing purposes, again, trying to sell your product. So Google, the elephant in the room. It launched in September of 1998. It's now so omnipresent that we forget there was a time where it wasn't around. And within a year of its inception, 1 billion searches per year were being performed. By 2000, more than half of Google users had searched for health information at least once. So very early in the adoption of this search tool by the public, more than half of its users were looking up health information. That just shows you what a natural instinct that is. As of 2019, more than 2 trillion annual searches were performed, of which 7% were health-related. So when you do the math there, that's more than 70,000 such queries per minute. And this is fascinating to me. So patients know themselves. Health-related searches double in the weeks before a patient goes to the emergency room, and about half of patients who use Google in the week prior to going will actually search for content that's directly related to their chief complaint. So I tell my students, my trainees all the time, the patients know what is wrong. They just need us to put the appropriate label on it and then treat them accordingly. So again, there is some disdain, some discomfort, if I'm honest, among healthcare professionals about this practice. I'm not fond of this mug, but you can buy this. Doctors have bought this. It says, "Please do not confuse your Google search with my medical degree." And you can tell here there is some irate reaction that we would go through all these years of training and presumably accrue wisdom through experience, and people would conflate that with what you get back from a Google search. And there's also, if I'm honest, a lot of negative PR for oncologists in particular on Google. So a couple years ago, I did a little exercise. You might know that Google will often auto-complete your search string to try to help you. So I put in the search string oncologists are, and I let Google do the rest. And it said oncologists are murderers, oncologists are evil, oncologists are confused, and oncologists are criminals. So maybe, and I'm not saying pity your poor doctor, you can start to see why physicians have a slightly skeptical view, shall we say, of what we get back from Google. However, there is a dirty little secret, and that is that doctors use Google too. This is an example of, again, a doctor who has demonstrated the utmost umbrage to Google. So what's happening here is there's I believe, a senior rheumatologist who is just absolutely affronted that a trainee would use Google to arrive at the correct diagnosis. And again, this man may not be familiar to you. This is Sir William Osler. He is often venerated as one of the greatest physicians, certainly in the American medical tradition. And he was a master diagnostician. And he was making his brilliant deductions long before Google was available. And this doctor, writing in 2005, was sort of envisioning that Sir William Osler would be turning over in his grave that we would use these modern information tools. But we do. So this was a fascinating survey performed several years ago now that asked 300 members of the American Medical Association, how often do you use the following resources to gain information to diagnose, treat, and care for patients? And look at this. Google comes in at number 3 on the list. How about that? Doesn't that seem hypocritical? But what I also found interesting is at number 2, just after professional journals as sort of the ultimate source of evidence-based literature, colleagues, our peers, were the second most likely source to go to for information. And I would argue that patients do the same thing. We go to like-minded, kindred spirits and ask them questions, just the same thing that happens in the physician community. We're people too. We have this human instinct to seek out our peers and ask them their opinion. And that outranks even search engines among how doctors arrive at their conclusions. So social media, I will be honest, I may be a little bit of an outlier here in that I have readily embraced social media in my personal and professional life. A lot of doctors fear to tread on social media. And again, it comes from a good place. I've already showed you what can happen on Google. Social media is a place where it's actually very easy for a doctor to stray and say accidentally disclose personal health information, which is a massive and arguably fireable offense. So many of my peers, and I don't blame them, have decided, you know what, I'm not going to have any professional presence on social media. And I respect that. However, I think it has to be recognized that social media is where many patients are congregating. And this is probably apocryphal, but I love the story anyway. So when the FBI finally located the famed bank robber, Willie Sutton, they said, hey, why do you rob banks? And he said, that's where the money is. And I would argue, especially during COVID, the nature of the pandemic has forced us into these virtual spaces to congregate with one another. So let's take a look at that. So Facebook, the elephant in the room. Obviously not a social media platform that is devoid of scandal, and yet I don't think you can have a discussion about social media and neuroendocrine tumors in 2021, as I record this, without mentioning Facebook. It is still, I think, the dominant presence. So of the public posts on Facebook, this is shocking to me, 7.5% are health related. I think it's very easy to sort of caricature Facebook as though it's updates from your high school friends and baby pictures, but there is a lot actually of information on Facebook that people are disclosing about their own health, and that's in the public forums. Once again, the patients will tell you what is happening with them, and in our somewhat demonstrative modern way, you can see this activity even on social media. So there were linkage studies to look at ER visits in relation to social media posts, and patients with a given diagnosis in our electronic medical record were far more likely to use terms related to that condition on Facebook. Patients will self-disclose signals about their mental and physical health. So these are word clouds around particularly depression and loneliness. And again, this is natural language processing, which is bringing these linguistic signals, these red flags, out of Facebook posts. So the signal is there if you care to listen to it. Somewhat troublingly, for a medical oncologist who does believe in evidence-based medicine and believes in research as the engine of progress, fewer than 1% of all these health-related posts concern clinical trials or research studies. So there's a lot of anecdotal evidence and very, very little actually strong peer-reviewed evidence is being cited on Facebook. So buyer beware. I'm a big believer in destiny sharing. Part of my diagnosis with a very rare neuroendocrine tumor syndrome was actually to co-found and co-moderate a Facebook group for patients with my syndrome. So I have multiple endocrine neoplasia type 1. It has an incidence of about 1 in 30,000 in the United States, which means that when I was diagnosed, I didn't know anybody like me. And by happenstance, I met at the Mayo Clinic where I was training one other person who had my diagnosis, and together we decided that we needed to have a digital presence. What's been fascinating to me over the years is with all the different reasons not to be on Facebook, whether that's Cambridge Analytica or leaks of information or the data being used for sale. And as Mark Zuckerberg has very freely admitted, Facebook sells ads. It is not a completely free charitable service. With all of that, the attrition from our group has been very, very little. So this happened now, gosh, several years ago. There was a group for BRCA survivors, so usually women with the BRCA mutation who'd been affected by breast and ovarian cancer, and they joined a private group on Facebook with the understanding that in that private group, their own identities, which again are tied to a genetic condition, would not be disclosed. And again, I'm not entirely sure there was any malice here by Facebook, but it turns out a relatively simple plugin in the Chrome browser allowed you to see the list of these patients' names, which was a huge sort of breach of the privacy that they understood that they had. So even with that, among health communities, Facebook is often seen as too important to delete. And indeed, this is my own group, American Multiple Endocrine Neoplasia Support. Over the last several years, we've only seen about a 2% attrition in membership because I think net patients like us, we find a real kinship online. I think there is value there. You just have to be aware of the trade-offs. You have to be aware of the trade-offs in the information you're receiving. And you also have to realize that what you take to be completely private may not be so. What about Twitter? So this is actually the platform where I feel most comfortable, and certainly where most physicians, if they're going to be online at all, will be found and will be active. So this is my Twitter profile. I am extremely upfront that I am a neuroendocrine tumor patient. That banner photo is actually a picture taken of me on the very morning of my Whipple procedure, right before I was wheeled into the operating room. So I think it's actually more important that I advertise I'm a patient, necessarily even than I advertise that I'm a physician, although you can see there my professional affiliations. This is what's really interesting to me also. As an oncologist, and I think you should know this about the doctors that might be taking care of you, Twitter has been gaining traction even before the pandemic. This is crucial. So the inflection point actually happened, I would say, in our professional community in 2019. So every year, every summer, usually in Chicago pre-COVID, all the oncologists from around the world would congregate in a massive sort of hangar-like convention center there, McCormick Place. And what happened in 2019 is we saw this upswing in oncologists using Twitter to communicate with one another. And again, I find that really fascinating. I actually think it's only intensified since then. You know, necessity being the mother of invention. If you want to talk to other oncologists right now, you can't really do that easily in person. So online is where you go. But there's a real need, I think, on Twitter with its constant flow of information to separate the signal from the noise. And hashtags are very, very helpful in doing that. And there we have to give credit where credit is due. So breast cancer advocates, patient advocates actually started what I think is the sort of foundational oncology social media hashtag in 2011 with hashtag BCSM, breast cancer social media. And from there, the floodgates opened. So shortly thereafter, brain tumor social media, which is presumably a much smaller group, but again, a very tight-knit community, followed with BTSM. And then after those organic examples, people, sometimes doctors, actually created hashtags deliberately so that we could have conversations congregating around certain topics. And so there was a rubric here, a rule to follow. So it had to be disease specific. The hashtag, of course, had to be short. It had to be unique or otherwise minimally used on Twitter to avoid confusion and the need for disambiguation. And it had to end in SM, which is a trigger to remember this is social media. This is online use that is visible to anybody. I think this is well known, but maybe not. You don't have to be on Twitter to see tweets. You can Google someone's tweet. So whatever you put on there is very, very literally public knowledge. The uptake in hashtags was fascinating because it was actually driven largely by patients and advocates. And here I think it's really crucial that we recognize the pioneering role that these voices played in establishing online oncology communities. If you look at this circular chart, the way that different stakeholders use hashtags, it is still predominantly used by patients and caregivers and advocates, more in some than by doctors or healthcare professionals. Okay, so this is a slide that gives me some pause because there's a somber reason for it that we'll get to. So the voice at this annual oncology meeting, ASCO, the proportion of voices, I should say, has shifted so that as the oncologists have gotten more vocal Unfortunately, that comes at a cost. And that cost means that advocates have been heard less. And again, this is based on influencer data put through this third-party data aggregation group called Simpler. At 2019, a colleague of mine and I, Chadi Nabhan, recognized this, and we wrote a commentary about the ASCO meeting. And we said, it's really, really important to have caregivers and advocates' voices heard at these meetings. We underestimate their sophistication at their peril, and it's crucial that we listen to them to shape the kind of research that we're doing. And I'll give you this one example, and it may seem semantic, but I think there's a lot more to it than that. So at this meeting in 2019, there was an abstract, there was a presentation about patients, and I'm going to put this in quotes, who had failed whole brain radiation therapy. These are people with cancer in the brain. And we said at that point, and more importantly, the advocates said, hey, listen, that phrasing, that's not appropriate. We didn't fail anything. The treatment didn't work for these patients. And I know it seems like a small thing, but just turning that linguistic phrase on its head and realizing that actually, if anything, it's failing, it's the treatments that we're administering is so crucial in getting oncologists to accept responsibility for outcome, which in turn drives better research. And this is just to say that long before COVID, I think it was really, really important that patients and advocates get involved in meetings virtually. And you'd be surprised just how receptive oncologists are at these times. A lot of us are very online, especially with these hybrid models. We live half at the meeting and then half in this meta meeting that happens in the virtual space. We will listen to patients and advocates who engage us there. But every oncologist eventually will think about clinicaltrials.gov. This is the repository, as you may know, the federally run repository for all the trials that are run. And I have to say, I think in recent years, this interface, which is run by the government, as you can tell by that .gov suffix, has gotten a little bit friendlier to patients. You can actually put in, under that country tab, you can put in not just the United States, but where you live exactly and how far you're willing to travel for a clinical trial. I think this is wonderful. There are still some problems, though, on how well this information can inform any given patient's search. So this is a quote that I thought was very telling. This is a patient commenting on the redesigned clinicaltrials.gov, because again, it's recently gotten more user-friendly, believe it or not. They said, I always felt like I needed some advanced degree to figure out if I qualified or not. Some trial listings had conflicting information or were just very scientific, not average Joe information. And again, I think this person might be too self-effacing, but the readability analysis of the study purpose statements that you find on clinicaltrials.gov showed that on average, you needed to have at least 16 years of education. So obviously that's going to take you K through 12 and then into the college level. The average read level in the United States, though, is 7th to 8th grade. And that's not, again, to talk down to anybody that's listening to this talk. It's how do we be public-facing and comprehensible? And then, by that metric, only 12% of Americans are fully health literate, as judged by the Department of Health and Human Services. So we have a struggle, again, to make things understandable, but also complete. That's kind of the tension there. The other thing I wanted to bring up, it's actually a relatively recent development that the patient voice was even heard in clinical trials. So this is a really nice timeline, I think, of the history of clinical trials. I don't know how well this is known either, but arguably the first clinical trial, this is a really great story, was performed on a British naval vessel in 1753 by a Dr. James Lind. And what he did was he gave half the sailors citrus fruits, and he observed the other half. And the half that got citrus did better in terms of how they acquired or didn't scurvy. This is where the term limeys came from, because after then it became standard issue in the British Navy that you'd be given limes. And the vitamin C content would help you stave off scurvy. But look at this. So from 1753, it takes until 1978, so more than 200 years later, before we see the first quality of life measurement done in sort of objective and proactive fashion in a clinical study. So the patient voice, unfortunately, is relatively recent in terms of how it's being listened to methodologically in these studies. That said, we actually belong, I think, to the oncology community that might have the most ample precedent for studying quality of life. This is literally asking patients how they feel. So the first example I could find of this that I thought was robust is in 1986. This was a study of long-acting somatostatin analog, that might ring some bells, in arguably our most prestigious journal, the New England Journal of Medicine. And look at this. Dr. Qualls and his co-investigators, again, largely from the Mayo Clinic, just like Dr. Mortel, who I mentioned earlier, actually measured outcomes in terms of flushing and diarrhea. So the qualitative impact of this then new treatment. Now, they quantified that with changes in urine 5-HIAA, but it was also qualitative, and you can see there how those lined up. When Somatuline, or lanreotide, became available as a somatostatin analog, we also looked at its impact on 5-HIAA and thus the symptom burden of disease. And then perhaps most recently, telotristat, which you might know as Zermelo, actually got its FDA indication specifically for symptom control, seeing this reduction in urine 5-HIAA, which then translated to a decrease in carcinoid diarrhea. So this study quantified, quite famously, the number of bowel movements carcinoid patients were having on a daily basis, and then documented the decrement in that frequency on this drug. So that quality of life benefit was actually the reason the drug got approved. So we belong, thankfully, to a research community that listens to our voices. So this is something I hate to say, and believe me, I hate to invoke this man, but this is, of course, Joseph Stalin. He said a single death is a tragedy, but a million deaths is a statistic. And what I'm getting at here is there are many, many numbers in oncology. I'm not defending oncologists, but you should know we're taught statistics, and we cite statistics in our practice, because if you come to me and ask me to predict your outcome, the best thing I can do is rely on patients that went before you, and that means invoking their range of experience, the range of their survival. Often I'll cite medians, the middle of a bell curve distribution. But to me, when I practice medicine, what I'm actually doing is I'm encountering their story one at a time. And this is something I wrote right after my diagnosis, when I said, when we critically assess the evidence that guides our management, we apply the rigor of statistics and discard underpowered studies as insufficiently robust. But each individual patient with cancer partakes in an ongoing, irreproducible experiment where n equals 1, by which I mean do not discount for one moment the importance of your own story. Your data point, for instance, should not get lost in aggregate with everyone else. And as has been said elsewhere at this conference, no two NET patients have an identical course. You are unique, and you should be recognized as such. So how do you go about telling a story and putting the pieces together? Well, I have a personal example here. So I had the Whipple procedure. Many of you may have had this also, to remove the head of my pancreas in 2017. And I found the Whipple very daunting, even as a doctor, to think about its anatomic complexity. I often say to my patients, this does to the upper abdomen what Picasso did to faces. You take the identifiable parts and you rearrange them. And so you start off with the anatomy there on the left, and you end up with the anatomy on the right. And it looks very, very different. Things are missing. Things are reattached. And the reason this particularly mattered to me to share my story is I'm a gastrointestinal oncologist. I have patients come to me all the time with pancreas cancer, and only 15% of them are eligible for the Whipple. And the reason for that is in the other 85%, these tumors have either already spread or they're so involved, so inextricably linked to the blood vessels around the pancreas that they can't be cut out. So in the remaining 15%, it's crucial that those people be offered surgery if they're eligible. And I have many, many people who've turned it down because they say, Doc, that surgery is too scary. It's too complicated. And I believe that monsters are more scary in the dark, meaning if I can shine a light on this procedure and I can show people step by step what it looks like, and if I can convince even one person who's eligible to then have the surgery, then I think I have done my part. So that's what I tried to do. And I used Twitter to do it. So again, don't try this at home, but this is how to chronicle your Whipple versus live tweeting. So I was extremely fortunate. So I work at a wonderful healthcare system in Utah called Intermountain Healthcare. It's the largest healthcare system here. We take care of patients in 6 states in the Intermountain West. And again, I'm very well resourced, and I have a fantastic social media team. And so what they did was they followed me the entire day of my surgery. This is pre-op. I'm gathered there with my surgeon on the far right, and my pastor next to him, and my wonderful wife next to him. And again, they followed me all day. This is a moment I shared with my wife before surgery. So actually one of my favorite pictures of us as a couple. And again, it showed the pre-op process. I'm trying to humanize here this journey. And then as a doctor, I have to say that it was very gratifying to see the engagement this had with traditional media. So I woke up from my surgery and I'd had 3 million impressions on Twitter, which was a staggering number. But then local news outlets, TV stations, and newspapers started picking up on this too. And my point there is this is non-binary. You can have both a social media presence and you can get attention from the more conventional journalists. This was an out-of-body experience for me. Thankfully for this part, I was completely under general anesthesia. You'll see there at the very bottom that my social media team took over my account, which led some of my friends to believe that I was being awoken from anesthesia to comment and then put back under. That's not how it went. But you can walk then step by step. I can walk then step by step through all the different parts of that procedure that day. And I now understand better what happened to me, and I hope that other people can too. I was not shy about the highs and the lows. The high there is on the left. That was the day I was discharged from the hospital. What you don't see in the middle is I was right back the next day, and then I was in for 5 weeks after that with a nasogastric tube, with a tube up my nose. I did document the moment in my life where that was removed. It ranks right up there with my wedding day and the birth of my children in terms of things that we celebrate. And I wanted to show that this is not necessarily linear recovery, and that, yes, doctors can get sick too. And I think there's real power as patients in sharing both the good and the bad. The bad not to scare people, the bad actually to validate that, listen, it's very good to go into an operation with hope and intention, but you should also realize that complications happen, and there's a whole community that's willing to support you through that. I had incredible outreach during this process of getting over the Whipple, and it was just absolutely touching to log on. There's a lot of bad on social media. I would argue there is more good. So if I have come this far, it's by standing on the shoulder of giants. I'm going to recognize a few people here, one of whom you know very well. So Josh is the United States neuroendocrine tumor patient advocate par excellence. I don't know if there's anybody that does it quite like Josh. So he's on Twitter. He's deeply involved with NorCal Carcinet. As you may know, he hosts prtinfo.org and has helped countless people at this point navigate PRT, especially before it was available in the United States. So he's incredible. Internationally, though, there's other NET advocates I want to recognize. So Ronnie Allen is a Scot. That's my homeland. I'm from Scotland originally. He's incredible. And then there's another group led by Simon Robinson, and he's assisted by Rachel Gunter. That's the NET Cancer Foundation, nonprofit, operated largely out of the UK. Also amazing. And this is far from an exhaustive list, of course. But if you're looking to model your behavior after anybody, I would suggest starting with these people. It's really remarkable what they're able to do across a host of platforms, whether that's their own website, Twitter, Facebook, you name it. So this is the other sad reason that we're seeing the drop-off in advocate voices. We cannot take our advocates for granted. So this was, again, back in 2019. I showed you the shifting proportions. We saw the advocates dropping off. And in a very real sense, we were losing these people. These advocates were passing away. They were dying of their disease. Some of these patients cited here were breast cancer patients. I also see it in the lung cancer community. I see it in the NET community. And I'm sure it's tremendously upsetting when we see our kindred spirits pass on. But that also means we should listen to these voices with the fierce urgency of now. And with that, I couldn't give this talk to this group without paying honor to Giovanna. I only got the chance to meet her once in 2017, but I know that she was quite literally the foundational presence of your group. And I think she showed you already in her remarkable life how to embody advocacy in the best possible sense. So this is partly in her loving memory. So parting thoughts. We are mighty as a herd. So again, yes, one at a time, we're individual zebras, but together it's hard to ignore our collective presence. There's still tremendous meaning, though, even despite this collective strength in your story, and you should not be afraid to share it. That doesn't mean that you have to waive your confidentiality, but you should know that other people have done this and have found, again, more resonance and more support than they have found objection or pushback. It's important to find your community. I think you're probably there already. If you're watching this talk, you know about LACNets, but there are other groups that aren't necessarily mutually exclusive and can also round out your experience. And this is a quote of mine, but one I completely believe in. The self-advocating patient is the most powerful force in medicine. Healthcare is very sophisticated. There are a lot of moving parts. I know in my own case, none of this would have happened to me if I had recognized that I had something wrong with me, and that was a neuroendocrine tumor syndrome. So please, 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 some of you have medical degrees. Frankly, you are an expert in your own body, and we ought to have the humility as doctors to recognize that. So please feel free to voice your concerns and speak your truth. And with that, I'll go ahead and close, and my contact information is there. Thank you very, very much.